is Marion Schaefer, and I work as an endoscopist at Nancy University Hospital in the northeast region of France. I am delighted to present our research on behalf of all my co-authors from 17 centers in France and Belgium. I would like to thank the editorial team of Endoscopy for offering us the opportunity to share our work. Patients diagnosed with cirrhosis may be at risk of developing superficial esophageal neoplasm due to overlapping risk factors like alcohol consumption, tobacco use, or obesity. As part of their screening and management for portal hypertension, these patients undergo upper GI endoscopy, which can lead to the detection of superficial neoplasm. However, performing endoscopic esophageal resection in such individuals can be challenging, and concerns primarily revolve around the risk of hemorrhage and also other complications which can result in liver disease decompensation and poor outcomes. Consequently, our aim was to assess the feasibility, effectiveness, and safety of endoscopic resection for superficial esophageal neoplasm in this specific patient group through a large multicenter study. Additionally, we sought to explore the specific management of portal hypertension in these settings, as we discovered that each center implemented its own strategies. The key finding of our study indicates that endoscopic resection is both feasible and effective. In this retrospective study, we treated 112 patients with 134 lesions using predominantly endoscopic submucosal dissection, along with a smaller number of cases performing cap-assisted endoscopic mucosal resection or ligation-assisted endoscopic mucosal resection. The rates of technical success and R0 resection were high and comparable to those observed in the general population. However, it's important to note that adverse events were slightly more frequent, with 8% delayed bleeding and 4% experienced cirrhosis decompensation. Endoscopists employed various methods to prevent bleeding, such as prophylactic transjugular intrahepatic portosystemic shunt placement, octreotide infusion, or endoscopic bone ligation before or during the procedure. Among the few cases of technical failure, only one was due to the periprocedural bleeding, and the patient was successfully treated after TIPS placement. Nevertheless, due to the relatively low bleeding rate, the study lacked sufficient power to compare these preventive strategies, and therefore no specific recommendations can be made. However, we observed more bleeding in the EMR group compared to the ESD group. Another noteworthy finding is that despite the occurrence of adverse events and the frailty of the patients, they derived benefits from endoscopic resection of superficial tumor, with improved survival among those who underwent curative resection compared to those with non-curative resection. These results underscore the necessity for specialized management of these patients, who should be referred to expert centers. This approach ensures the provision of appropriate therapy without undertreatment of endoscopically resectable lesions, with ESD in the same indication than general population. Moving forward, the next step will likely involve collecting prospective data to compare different prophylactic management methods for portal hypertension, and these new data will likely focus specifically on ESD, given its better oncological outcomes without an increased risk of bleeding in these patients. Thank you very much for your attention.